right, good morning, everybody. Welcome back to another year of Medicine Grand Rounds, and welcome back to Clopton Auditorium. It's been a while, but hopefully we are here to stay. There's been a lot of renovations with the AV system over the last year, so fingers crossed that we'll be here from here on out. I am Stephanie. I'm one of the medicine chief residents, and along with the chiefs and Dr. Fraser, kind of the producer per se of Grand Rounds. And as always, I just wanted to thank you all for coming in person. A special thank you also to Dr. Ben Humphreys in Nephrology, who's been one of our most ardent supporters and helping get people come out in person, because it really does make a difference. We, of course, appreciate people who are joining us via Zoom, but thank you to those who are here in person. Today, we have an excellent talk with Dr. Ravi in Oncology and Dr. Tingting from Nephrology. They're both expert clinicians, clinical investigators, avid mentors and educators, and today they're going to give us a joint perspective on monoclonal gammopathy of renal significance. So without further ado, Dr. Lee.
Thank you, Dr. Socius. Thank you for inviting us to give grand rounds today. It's my pleasure to present with Dr. Vij on the topic of monoclonal gammopathy of renal significance. Now, monoclonal gammopathy of renal significance, or MGRS, is a hematologic condition defined by renal manifestations. Therefore, it's the perfect topic for a joint onco-nephrology grand rounds. I'll be giving the nephrology portion of the talk, and Dr. Vij will later give his perspectives from the oncologic standpoint. These are our disclosures. This is the presentation outline. We'll be given an overview from definition to treatment of MGRS. I would like to start with the case. We have a 45-year-old male without significant past medical history who presented for evaluation of acute kidney injury with a serum creatinine of 2.1 and subnephrotic proteinuria of 2.7 grams a day. Blood pressure was a bit high, but the rest of the exam was unremarkable. Urine showed 3+ protein, 3+ blood, some dysmorphic RBCs, and some RBC casts. The renal ultrasound was normal. The serologic workup, as indicated here, was entirely negative, so a renal biopsy was obtained. Now, on renal pathology, the findings of the light microscopy were consistent with proliferative glomerulonephritis. On immunofluorescence, there was moderate staining of IgG, later subtype to be IgG3. There was pretty strong staining for kappa light chain, but very minimal staining for a lambda light chain, indicating there is a monoclonal process going on here. On electron microscopy, there is some subendothelial deposits and some mesangial deposits. So these findings led to a diagnosis of proliferative glomerulonephritis with monoclonal immunoglobulin deposits, or PGN-MID. So the monoclonal process was unexpected because the patient was very young. Obviously, we're concerned about a hematologic malignancy. So further workup was pursued. The patient was found to have an abnormal SPEP with a M spike of 1.9 grams per deciliter. The serum immunofixation was positive for an IgG kappa paraprotein, which seems to be the same protein that was deposited in the kidney. UPEP and urine immunofixation were negative. Serum free light chains shown here showed a ratio of kappa to lambda ratio of 1.22, which was normal. A bone marrow biopsy was entirely negative without any increase in plasma cells, and the Congo red stain for amyloid was negative as well. The subsequent hematologic evaluation, including the skeletal survey, CT, and PET scans were all negative. So to summarize the case, we have a 45-year-old man with the biopsy diagnosis of a proliferative glomerulonephritis with monoclonal immunoglobulin deposits with kappa restriction. There was a small M spike with IgG kappa paraprotein, and the rest of the hematologic workup was unremarkable. So based on these findings, we conclude that this patient has a monoclonal gammopathy, defined here. And the monoclonal protein here has been deposited in the kidney and has led to significant renal injury. So the questions here are, what is the underlying hematologic condition here? And how should we manage this patient's kidney disease? So if you look at the traditional classification system for monoclonal gammopathies, our patient doesn't really fit in here. These disorders shown here are classified based on the type of clone. Is it plasma cell? Is it B cell? And based on the tumor burden, how much bone marrow is involved, how big is the M spike, and whether or not there's any organ damage or organ dysfunction. So there are specific criteria that dictate whether or not clone-directed therapies should be initiated. Typically, the patient will have to meet the tumor burden criteria and have organ dysfunction at the same time. For example, in multiple myeloma, you have to have a minimal bone marrow involvement, more 10%, or have a M spike of more than 30 grams per liter, plus having one or more of the myeloma defining events. Then you treat the patient. Same goes for Waldenstrom's, and same goes for CLL. But for patients with smoldering myeloma, for example, these patients, even though they do meet the tumor burden criteria, they do not have organ damage. So we monitor these patients over time. For patients with MGUS, or monoclonal gammopathy of undetermined significance, these patients do not meet tumor burden criteria and they do not have organ damage. Therefore, these patients will be observed over time. Our patient does not meet the diagnostic criteria for any of these conditions. Therefore, the patient, based on this classification system, will not be really qualified for any clone-directed therapy. In fact, for a long time, when patients were diagnosed with monoclonal immunoglobulin-related renal disease, in the absence of a malignancy, such as myeloma or B-cell lymphoma, they were considered to have a MGUS-like condition. Not really MGUS because they have renal damage, so MGUS-like. But the problem with the terminology is that it implied a benign condition, therefore undermining the significance of the renal disease, impeding the efforts to develop treatment guidelines for this population, and also created reluctance amongst hematologists and oncologists who wanted to offer clone-directed therapy to these patients. Now, if you look at all comers, all patients with monoclonal immunoglobulin-associated renal diseases, most of these cases actually occurred in the absence of a hematologic malignancy. So majority of these patients, you can see that I have a few examples listed here. Anywhere from 40% to 96% of the patients did not have a concurrent hematologic malignancy that required treatment. So most of these patients were not treated. The only exception is amyloidosis, right? For example, AL amyloidosis. And these amyloidosis obviously is a long recognized condition that is associated with the high morbidity and mortality. And we already have standardized treatment protocols in place for decades now. But the rest of the people were not being treated. So how did these patients do without appropriate treatment? Well, they didn't do so well. Their disease usually progressive with high rates of end-stage kidney disease. And some patients were able to get a kidney transplant after reaching end-stage kidney disease. However, the recurrence rates in the allograft were really, really high, up to 90% in some studies. These patients were also at a high risk of progression to a hematologic malignancy. A recent study showed that there is a 10% risk of progression to myeloma in the first year, compared to only 1% progression in MGUS patients. And the diseases in this category are very poorly responsive to the conventional immunosuppressive therapies, which we used to use to try to delay the progression of the renal disease, but they didn't work. And for the few people who were able to receive clone-directed therapy, we noted that the patients actually went into either complete renal remission or they stabilized their kidney function. So because of the poor outcomes, the patient outcomes, poor renal outcomes, many in the nephrology community and in the hematology oncology community felt that it was necessary to devise a better classification system to include these patients and to discriminate them from the MGUS population. So in 2012, the International Kidney and Monoclonal Gammopathy Research Group coined a new term, a monoclonal gammopathy of renal significance, or MGRS, to acknowledge the causal relationship between the monoclonal protein and the renal disease, and to also increase the recognition of this group of unique disorders. So MGRS applies to any B-cell or plasma cell clonal lymphoproliferation with both of the following: kidney lesions that are related to produce monoclonal protein, means that you have to prove that the monoclonal protein is nephrotoxic, causing the damage that you see in the kidney. Number two, the underlying plasma cell clone does not meet the current hematologic criteria for specific therapy. So one example is multiple myeloma. Like these patients have a tumor burden, but they do not meet criteria because they don't have an organ damage. But if a patient with multiple myeloma develops any of these monoclonal immunoglobulin-related kidney diseases, and that patient will now have MGRS, you will treat the patient as such, as long as that renal disease is not one of the myeloma defining events. If that's the case, you'll treat them as myeloma. So the inclusion of MGRS in the newer classification system, separate from MGUS, really has facilitated the adoption of clone-directed therapies in this population, and has also had implications in coding, in billing, in research, and research funding. So MGRS encompasses a wide spectrum of complex and heterogeneous disorders, as shown here. And these diseases have distinct disease mechanisms, histopathology, as well as outcomes. But they all share one common etiology, which is the nephrotoxic monoclonal protein. So these monoclonal proteins can be free light chains, like gamma light chain or kappa light chain, or they can be intact immunoglobulins. And very rarely, a free heavy chain can be the culprit monoclonal protein. MGRS-associated renal lesions can be classified in two different ways. One is based on the localization of the monoclonal deposits and site of renal injury. So this is the glomerulus. You can see that inside is the glomerular cuff, enclosed within the Bowman's capsule, which is in continuity with the proximal tubule. On this side is your vascular pole with your afferent and afferent arteriole. Now, most of the MGRS lesions are located within the glomerulus. Very few are tubular in origin, tubular in nature. Some diseases, such as amyloidosis and light chain deposition disease, can affect multiple renal compartments. Now, the size of the monoclonal protein actually matters in determining where the deposits might occur, where the renal injuries might occur. For example, free light chains, not only can they deposit in the glomerulus and cause injury there, they're small. They can be freely filtered through and to get through tubulus and cause tubular injury as well. Intact immunoglobulins are really large. They don't get filtered through, so their injury is usually limited to the glomerulus only. Now, perhaps a more common way to classify these MGRS-related lesions is based on the presence or absence of monoclonal protein deposition in the kidney. So there are a couple of disorders, C3 glomerulopathy and thrombotic microangiopathy, or TMA. These two disorders do not actually have monoclonal deposits in the kidney. The renal injury here actually is due to an indirect mechanism, but as a result of monoclonal protein. We'll touch upon that in a little bit. But if there are deposits present, then we categorize them as being organized or non-organized, based on the characteristics that we see on electron microscopy. Non-organized just means, well, the deposits don't look like anything. There's no patterns or structures to them. When they're organized, there's distinct structure to it. On electron microscopy, what we can see is they can look like fibrils, they can look like microtubules, or even crystals and inclusions. And there are a few entities falling under each category. You don't really need to remember the names. I just wanted to illustrate that there's a variety of these types of disorders. But I also wanted to show you some nice pictures to show you more about how they look actually on electron microscopy. But before I do that, I wanted to have a quick word on renal pathology. So once we do a biopsy, we have the renal tissue, we get processed. They then undergo evaluation via 3 complementary steps. The light microscopy is a step that determines the lesion, the histologic pattern of injury, right? We use standard stains and some special stains, such as Congo red, to provide additional information to help us arrive at the right diagnosis. Immunofluorescence really determines the presence or absence of immunoglobulins, complements, or light chains, right? It tells us where the deposits are, and also it is a step that helps us determine the monoclonality in MGRS. Electron microscopy enables us to visualize detailed tissue and cellular structures, and also tells us how the deposits look, where they are there any patterns or features to them? So electron microscopy is actually the basis for the classification of the MGRS lesions. Let's take a look at some pictures of monoclonal deposits. So this is from a patient with a light chain MGRS. So these are light chains. You can see these are thin hair-like strands. These are actually fibrils. They're straight, randomly arranged, non-branching, measuring usually about 7 to 12 nanometers in diameter. And this is actually characteristic for amyloidosis. This is from a patient with AL amyloidosis. Of course, on electron microscopy, you're not able to say this is light chain or this is AA or this is TTR amyloidosis. All amyloidosis look the same, but there are additional testing. There is additional testing you can do to subtype the amyloid here. On the right of your screen is a different type of fibrils that you can see in a different disease, fibrillary glomerulonephritis, which is a very rare type of glomerulonephritis. The fibrils you see here are actually the intact immunoglobulin, usually immunoglobulin G. They're a little bit bigger than the amyloid fibrils, measuring about 16 to 24 nanometers. And when you see this, these are very characteristic for fibrillary glomerulonephritis, and you're not really thinking too many of other differential diagnoses. Some monoclonal proteins look like this. This is from a patient with a monotypic IgM. You can see that these monoclonal proteins range in a parallel fashion. They're very large and microtubular in structure and with hollow centers measuring about 17 to 60 nanometers. This actually is from a patient with immunodactyloid glomerulonephritis. This obviously is quite different from the amyloid fibrils that we saw on the previous slide because the nature, the characteristics of monoclonal proteins are quite different. Finally, I have another picture from a patient with a monotypic IgG MGRS. What this is, these are actually cryoglobulins. They're also microtubular, but really you can see those distinct structures as well as this one on the left. These microtubules are a little bit shorter. They're curved, sometimes curvilinear. Sometimes on electron microscopy, you can actually see things that look like fingerprints, okay? So this is a pretty classic for cryoglobulin glomerulonephritis, and then you can see type 1 or type 2. In several of the MGRS lesions, the monoclonal proteins actually appear as crystals. They're really actually very pretty crystals. For example, in light chain proximal tubulopathy, in either the cytoplasm or the lysosomes, these kappa light chains can precipitate as geometrically shaped crystals. It's very interesting. These crystals actually are associated with Fanconi syndrome many times. There's also a non-crystalline form of light chain proximal tubulopathy. There is no crystals. You see these non-crystal inclusions in either the cytoplasm of the tubular cell or in the lysosomes. And these are usually lambda light chains instead of kappa that we see here. And this particular disorder is not so much associated with Fanconi syndrome. I want to just show you a couple of cool pictures. This is a crystal storage cytosis. I've never seen a case myself, and it's extremely rare. It tends to be a systemic disorder that's associated with monoclonal gammopathy. These light chain crystals, usually kappa, they actually deposit within histiocytes. In the glomerulus, we can see them. We can see them in the interstitium, but you can also see them in the lungs, in the kidney, in the liver, in the skin, sometimes in the brain. And finally, crystal globulin glomerulonephritis, again, an extremely rare disease. What this is that these monotypic IgG, the immunoglobulins, actually precipitate within the capillary lumens, forming these dark, very dense crystals. They look kind of like pseudothrombi. They obstruct the lumens and cause injury and inflammation. So those are organized structures. So it's amazing how these monoclonal proteins can take on so many different forms in the kidney. The non-organized deposits, just a quick look at those. So monoclonal immunoglobulin deposition disease is one of the examples. You can see that there are these kind of dense, granular, powdery-like granules that are along the glomerular basement membrane. It's almost like you took some of these things and you kind of sprinkled along the tubular and the glomerular basement membrane. Even though the deposits are not organized, they actually look quite characteristic for MIDD. And in PGN MID, which is the case that we presented, the electron-dense deposits here are the monoclonal proteins. So as you can see, there's just no structure or pattern to them. So given what I just presented to you, you can imagine how complex the disease mechanisms can be in this group of disorders. We don't know how the monoclonal proteins cause renal injury, and we don't know why there's so many different histologic patterns as a result. But at the very basic level, we know there are a couple of mechanisms. One is direct, meaning that the direct deposition of monoclonal protein in the kidney can cause injury. The indirect mechanism is when there's no deposition of the protein in the kidney, but the monoclonal protein is able to cause kidney injury via a different mechanism. Frequently, it is the complement activation induced by the monoclonal protein. There are several factors that influence the intrarenal deposition of these monoclonal proteins. Just briefly, the innate structural characteristics, the physical chemical characteristics of these monoclonal proteins, including the sequence heterogeneity in the variable and the constant regions as a result of various mutations, can be quite influential in terms of where the deposits are located in the kidney. Also important is the biochemical and physical features of the renal tissue. So is the interaction between the monoclonal protein and the kidney tissue itself. As I mentioned before, MGRS results from a low level of clonal proliferation, right? So the tumor burden is not the problem. It's not the cause of the kidney damage. It is the nephrotoxicity of the monoclonal protein. So just a couple of quick examples. In light chain deposition disease, these light chains are kappa light chains. They're quite different from the light chains that are normal. So they have these hydrophobic side chains, so they have these abnormal glycosylation sites in the variable domains, so that these features enable these light chains to aggregate and precipitate in the kidney tissue. These light chains are also positively charged, so they're more likely to bind to the negatively charged glomerular basement membranes and tubular basement membranes. Now, in amyloidosis, the light chains are different. They're lambda light chains. Due to a number of mutations and amino acid substitutions, these light chains are very prone to misfolding, and they form these amylofibrils, and they're very resistant to proteolysis. So once they're in the tissue, they're in the tissue. So they really disrupt the normal architecture of the kidney. In light chain proximal tubulopathy, these light chains have these peculiar mutations in the variable regions where they are, again, very resistant to proteolysis. So once they're taken up by the proximal tubules in the kidney, they basically stay there and then they crystallize and form those crystals I just showed you. And PGN MID, this is an interesting disease in that about 70 to 80% of the patients with this particular condition do not have a detectable clone or a detectable serum or urine protein. So you find nothing except for the monoclonal protein in the kidney. That means that these patients actually produce a very small amount of the monoclonal proteins, but they have high affinity for the kidney, so they get trapped there. And these monoclonal proteins can fix C1q very well, so that they can activate the classical complement pathway, leading to inflammation and injury. Now, just as I mentioned before, there are a couple of conditions that do not have monoclonal deposits in the kidney. So how do the monoclonal proteins cause injury, right? So what they do, because they act like autoantibodies, what they do is they bind either to factor H, which is the regulatory protein in the alternative complement pathway, or bind to the C3 convertase in the complement cascade. The net result is the excessive complement pathway activation. In C3 glomerulopathy, is the alternative complement pathway, and in TMA, it's both classical and alternative complement pathway. Now, moving on to some epidemiology. So how common is MGRS? Well, the true incidence and prevalence are not known at this time. I know that recently a study was published in China looked at close to 700 patients with monoclonal gammopathy who underwent biopsy. 38% of those patients actually had MGRS. A study out of Vanderbilt showed that out of 121 patients with MGUS who underwent kidney biopsy, 42% of these patients had MGRS. A study from Mayo Clinic showed 40% of their patients had MGRS. So these numbers are quite impressive, quite unexpected to me, actually. I thought this was a more rare disease. These numbers really emphasize the importance of recognition of this entity, right? We need to be all aware of the existence of MGRS, because if you have a patient with MGRS who now suddenly develops some renal abnormalities, and that patient needs to be evaluated. Additional testing needs to be done, referral to nephrology perhaps, and possibly a renal biopsy. In terms of the types of MGRS, in all studies that I've reviewed, amyloidosis appears to be the most common type of MGRS. We can see the frequencies of the rest of the disorders, and there are some differences in frequencies in these disorders because these are different populations. This is from China, this is from the Mayo Clinic, the US population, and the last column is the international cohort. Just a few words on clinical features. Now, the clinical manifestations of MGRS-related kidney diseases can be variable, but they are largely dependent upon the site of the kidney that's affected and the degree of kidney dysfunction, as well as whether or not there is any extrarenal manifestations. As I said before, most patients have a glomerular presentation where they present with proteinuria, often with a nephrotic syndrome, sometimes with hematuria and varying degree of renal insufficiency. Hypertension is quite common, although in amyloid patients, hypotension is more common. Edema can be seen in nephrotic syndrome or in patients with advanced kidney disease. In tubular diseases, there's usually minimal albuminuria. There can be evidence of Fanconi syndrome and varying degree of renal insufficiency. It is important to look for extrarenal manifestations because these findings can help us narrow down our differential diagnosis. Now, in terms of diagnosis, I wanted to make sure that we all know that not every patient with MGUS and kidney disease has MGRS. We need to have a kidney biopsy and clinical pathologic correlation to make that determination. The earlier we diagnose these patients, the earlier we can treat these patients and better the prognosis. A study out of UK looked at renal survival in patients with MGRS. What they showed was that if patients presented early in their disease course, earliest stage of kidney disease, their renal survival over time was much better compared to those who presented late in the stage, emphasizing the importance of early referral to nephrology. Now, when should we do a biopsy in these patients? So listed here are the general indications for kidney biopsy: unexplained AKI, unexplained CKD, unexplained proteinuria. A study from Mayo Clinic actually found that several clinical features can be strong predictors of finding a MGRS lesion on a biopsy. And these are proteinuria more than 1.5 grams a day, hematuria, and abnormal free light chain ratio. So if you have a patient with these clinical features, it's really important to evaluate this patient and to pursue a renal biopsy. So the final diagnosis of MGRS or of monoclonal immunoglobulin-associated disease is the integration of these three steps that I mentioned before. And it requires the diagnostic expertise of a nepropathologist and also the effective communication between the nephrologist and the pathologist. So when we have a diagnosis like this, we can't really say this patient has MGRS yet, because the patient more than likely has not undergone a thorough hematological evaluation at this time, and a hematologic malignancy has not been ruled out. So this is when I refer this patient to my hematology oncology colleagues for further evaluation. Now, as you can see, that the care of a patient with MGRS requires a multidisciplinary approach with close collaboration between nephropathology, nephrology, hematology, and oncology. So back to the case. So we've got a patient with a proliferative glomerulonephritis and monoclonal IgG deposits with kappa restriction. The moment that I hear this from our pathologist, I'm referring that patient to our hematology oncology colleagues. I'll be referring that patient to Dr. Vitch for additional evaluation and treatment. But that doesn't mean that my job is done, right? As a nephrologist, I will be managing this patient's disease and all other aspects of this patient's kidney disease, including their volume status and employing different measures that can reduce proteinuria, blood pressure control. If they do develop CKD, I will be managing the other aspects of CKD. The nephrologist should be working closely with the hematologist and nephrologist to ensure the best possible outcome of the patient. Now I'm going to hand over to Dr. Rich. Thank you so much.
Thank you. So I'm going to try to provide the oncologist perspective now, once the case has been handed over to us. So the oncologist evaluation of MGRS is pretty much like we do for any plasma cell dyscrasia. We start off with SPEP and serum immunofixation. Unlike our nephrology colleagues that have given up with 24-hour urine collections, we certainly are still stuck in the old age of 24-hour, at least at the beginning, collection with electrophoresis and urine immunofixation. And then the serum-free light chain assay is ordered. Just a basic primer on serum-free light chains. The kappa chains are produced at twice the rate of the lambda chains in a patient in a normal state. Glomerular filtration and kidney excretion of lambda, which is a dimer, is slower than kappa. And the reticular endothelial system becomes an important route of administration with worsening kidney function. And though we have certain normals that we always have provided by a laboratory in terms of what the normal range for kappa and lambda are, which are shown in the footnote below, and also to keep in mind that half the labs in the country report this in milligram per liter and half in milligram per deciliter, which can really throw you off because that is by a factor of 10 or different. So in our institution, it's actually reported in milligram per deciliter. So 3.3 to 9.4 milligram per liter is 0.3 to 1.94 milligram per deciliter. And likewise, the lambda light chain is 0.5 to 2.6 milligram per deciliter. The ratio obviously remains unchanged. But what we also have clearly learned, given the excretion of these by the kidneys and the reticular endothelial system and the varying levels at different levels of renal dysfunction, that their ratio is different in patients who have just underlying renal dysfunction. Could be as a result of the renal dysfunction, not just the cause of the renal dysfunction. This also becomes very frustrating, not only in MGRS cases, but also in cases of myeloma. And this study done out of Iceland, where they actually looked at several hundred patients, sorry, this keeps moving forward, showed that depending on the EGFR, the range of the kappa and lambda light chain and the ratio is different. And as you have worsening levels of renal dysfunction, your accepted ranges for kappa and lambda both do go up. So in addition, we do do a bone marrow aspirate biopsy. We, on the biopsy, do routine pathology, but also immunohistochemistry looking for the CD138 stain. The fact is that when we get a biopsy and an aspirate, we can come up with 3 different values of plasma cells. One is of the aspirate, which is a 100-cell differential. The other is of the core, which is immunohistochemistry for CD138. And then there can be a value by flow cytometry as well that is provided. What we have clearly learned is that it's really the immunohistochemistry on the core that is most reflective of the true percentage of plasma cells in the bone marrow, because the aspirate and the flow cytometry can be heavily diluted by just blood. In the case of amyloid, especially if we find it in the bone marrow itself, we would also send for mass spectroscopy of the amyloid deposits, because even in patients who have a monoclonal protein, in a sizable proportion of patients, between 10 to 20% actually, we may find that the amyloid is unrelated to the light chain and could be TTR amyloid, or in rare cases, AA or other rare forms of amyloid as well. So doing mass spectroscopy on the amyloid deposit is absolutely essential. And just assuming because a patient has a monoclonal protein that the amyloid is related is a fallacy, and that could be costly because giving treatment for AL amyloid, presumed AL amyloid, is not going to help a patient with a TTR amyloid. And then we do look at cytogenetics and FISH testing in all our plasma cell dyscrasias. This may not be of much relevance in MGRS at the moment, but in myeloma and in amyloid too, the presence or absence of certain genetic abnormalities is prognostic. And one of the abnormalities, which is 1114 translocation, may actually in the near future have targeted therapy, namely venetoclax or BCL2 inhibitor, that may be helpful for these patients. I have not put up here the imaging studies that we do for our patients with plasma cell dyscrasias, but as mentioned by Dr. Lee, our skeletal survey, MRI, and PET scans in the appropriate circumstances are done. Now, I'm going to restrict my talk on the treatment aspect to just the three more common entities that we see over here. One is amyloidosis, other is the monoclonal immune deposition disease, and then the glomerulonephritis with monoclonal immunoglobulin deposition. And just providing a very high-level overview of the treatment. Now, first of all, in our plasma cell dyscrasias with deposition of light chains and amyloid deposits, we have only one thing in our armamentarium, and that is to reduce the production of the amyloidogenic or the light chains that are the cause for the deposition in the organs. We, at the moment, do not have any treatment that will get rid of deposited amyloid. That may change in the future. There are a couple of treatments in development that are purported to possibly increase the elimination of the deposited amyloid as well. So the analogy I give to my patients is that if you got a sink with some deposition of water there, and then you got the tap still running, all we can do is we can shut off the tap. And we have no way for us to get rid of the water that's already in the sink, and that is the tincture of time. And that's one of the more frustrating parts of this, as you see, that though we can show improvement in hematological parameters in a sizable proportion of patients fairly quickly, we are not often able to provide the patient often with relief that quickly. So looking at the approach to patients with amyloidosis first. So a patient with AL amyloidosis, the first thing we assess as an oncologist is this patient a candidate for an autologous stem cell transplant, which is mainly, is this patient going to be able to withstand a very high dose of melphalan and be able to live through a week or 10 days of aplasia in the hospital. Now, amyloid patients, unfortunately, have multi-organ dysfunction, and they often have got poor performance status. And I'm not delving deep into the treatment of amyloid. My colleague, Dr. Goldstein, is due to give a talk on amyloid in a couple of weeks, so I think I wanted to leave it to him to have, as he's our resident amyloid expert, to talk to you in a little more detail about what's going on in amyloidosis. But just to tell you, the standard of care is, again, as I stated, to try to see if a patient is a candidate for transplant. If a patient's a candidate for transplant, we give them 2 to 4 cycles of a bortezomib-based regimen. Bortezomib is a proteasome inhibitor, and it's usually combined these days with Cytoxan, dexamethasone, and daratumumab, which is a CD38 antibody. So a 4-drug regimen. It's FDA approved for the treatment of AL amyloidosis. And patients after 2 to 4 cycles, if they're transplant candidates, move to stem cell transplantation. And then the convention is about 3 months post-transplant, we assess what level of hematological response they've had. If the differential between the involved and the uninvolved light chains is reduced to less than 40 milligram per liter or 4 milligram per deciliter in our institution, then the recommendation is to just observe. Unlike in multiple myeloma, where maintenance therapy is currently the standard of care in the post-transplant setting, there is no data in amyloid that post-transplant maintenance would change things. For patients who don't meet that level of response, this level of response is what defines a very good partial response in the schema of response assessment, which we'll go through in a minute. And for them, looking at alternative treatments, again, this is still, though amyloid is a somewhat more common disease than some of the other MGRS entities that we are talking about, still there is very fragmented data on what to do in patients once they have failed frontline therapy. And part of it is because very few trials have been done in the past in amyloidosis, mostly because myeloma is a more common entity. Drugs get approved in myeloma and they're used off label in amyloidosis. And because a lot of the drugs that we use in myeloma, which has undergone a sea change in therapeutics in the last 20 years, are relatively new, we haven't built up a body of even case series and to tell you which is the best drug to treat refractory amyloid with. But just to state, in myeloma, we have dependence on now mainly four classes of drugs. One is proteasome inhibitors, one is which we've talked about, of which Velcade, Kyprolis, and then Laro. We have immunomodulatory drugs, the old thalidomide, lenalidomide, and pomalidomide. We have monoclonal antibodies to CD38, cetuximab, and daratumumab. And we have an antibody to another antigen on the plasma cells, SAMF7, called implicity. So those are three classes. And the next one that just is starting to get into the practice armamentarium is therapies targeted to B-cell maturation antigen, BCMA, which are very effective even in later lines of therapy. Obviously, steroids are a mainstay of any treatment thrown in with these agents as well. And sometimes we still use our old-fashioned chemotherapy drugs. So those are the alternative therapies that are referred to here. But the majority of patients are actually not a candidate for stem cell transplantation. And for them, 4 to 6 cycles of, again, a bortezomib-based regimen is what is recommended. And if they don't progress, and first of all, you check after 2 cycles if a 50% reduction in the differential of the free light chains is achieved, and after 4 to 6 cycles that this is actually reduced to the VGPR level of less than 40 milligram per liter differential. And if so, then observation alone. And however, if at any time these endpoints are not reached or patients progress, then once again, you use one or more of those drugs that I mentioned that we have used in myeloma. And honestly, very little systematic data exists to guide us as to which of those options is best. Often what we use is the side effect profile of the drugs to assess. Some drugs cause nephrotoxicity, some cause cardiac toxicity, some cause neuropathy. So sometimes our choice of agent is tailored more so by what the side effect profile of the drug is and what a patient can potentially tolerate. The next entity is the monoclonal immune deposition disease states. Here, data is very limited. Again, this is an entity that we usually use the same approach that we use for multiple myeloma in case it is an IgG-driven disease. And if it is an IgM-driven disease, use one that is more akin to how we treat B-cell lymphomas with. And the role of autologous stem cell transplant in this disease is less clear, but it is often considered in select patients who have a good performance status and no significant extrarenal manifestations if the patient has achieved only a partial response. So what we're aiming for, as we said, is a very good partial response, which is a 90% reduction in the hematological parameters. But if we are stuck at 50% and we've not got to the 90% level, then could consider autologous transplant. But again, this is not based on any randomized data, and the case series of patients undergoing transplant is limited to 20 to 25 patients from each center, and it's impossible to know whether doing the transplant altered the natural history of the disease for those given patients. And then there is the entity, the case that was discussed, that is the patient with the proliferative glomerulonephropathy with monoclonal immunoglobulin deposition. And, if one sighs once or twice for the amyloid and MIDD patient, when we see them, I sigh three or four times when I see a patient with this entity, because, this is an entity where 70 to 80%, as just stated by Dr. Lee, do not have a monoclonal protein or an abnormality in light chain, and they don't have any clonal cells in the bone marrow. So we're told this patient has got a hematological problem, which we can't identify at all. So we are used to using our somewhat toxic drugs, though they are becoming much more well tolerated, in patients who have 90% plasma cell involvement, have got lytic lesions in the bone. Yeah, they sometimes have kidney problems, but we're looking at a patient who's usually got very overt plasma cell disorder. And here now we're faced with a situation where you can't even find the plasma cell disorder, but because it's monoclonal in the kidneys, we are, now starting to see if the patient should be treated with drugs that are approved for plasma cell dyscrasia. So how does the algorithm go in this case? So again, first you say, is there a detected plasma or B cell clone in your bone marrow? If it is it a plasma cell or is it a B cell? If it is plasma cell, then you give chemotherapy like you would do for the plasma cell dyscrasias, Velcade, Cytoxan, dexamethasone these days, if insurance would allow it, add daratumumab. If it is a B cell disorder, then you go with what my lymphoma colleagues do, which is more bendamustine Rituxan or Revlimid with Cytoxan and Decadron, Rituxan with Cytoxan and Decadron approach. On the other hand, the majority are not going to have a detectable B cell clone. So here, you say, is there a detectable monoclonal protein in the blood or urine at least that we are treating? Once again, if we say yes, then depending on whether it's a plasma cell or a B cell clone, we use the same approach outlined before. But the vast majority, as I said, have neither a plasma cell clone in the bone marrow nor a detectable monoclonal protein in the serum. And there, obviously, you look at whether the patient does have subacute kidney injury and proteinuria greater than 1 gram a day. And usually, if they've been referred to us, they usually do meet that criteria. And if so, then again, we go down the same route that we talked about, plasma cell or B cell dyscrasia. And the conservative management decisions usually, I think, as Dr. Lee mentioned, occur at her end. And the patients, if they lack those kind of endpoints, then could be followed. And as you can see here, there's a lot of nebulous words here, shared decision making. And, you ask the patient what would they want to do, and if they want treatment or not, and then you move to treatment, send them to us if they want treatment. So if we do treat our patients, the response assessment, as I said, this is what we use in amyloidosis, and we've kind of extrapolated to use in the other two conditions as well. Complete response is obviously, you don't see any abnormality in light chains, but in the latter entity, as I discussed, we don't even have anything to start with. And then very good partial response, as I defined, is the differential falling to less than 40 milligram per liter. Partial is a 50% reduction. Now, there are also, for amyloid, specific organ response criteria that have been put in place for clinical trials. Referring to the kidney, kidney response is defined as a 50% reduction in proteinuria, which should have at least been at the baseline 500 milligrams of proteinuria. The prognosis of these patients, we have data mainly for amyloid, and we have a number of prognostic systems that are out there now. This one is one that provides, I think, the widest differential in terms of the outcomes between stages of disease, and these are based on the cardiac and TNT and the pro-BNP levels. As you can see, outcomes vary from 2.5 years to more than 11 years for amyloidosis. And what we also know is the survival does depend on the level of response attained. If you have a very good partial response and a CR, you're much likely to be alive far out than those that we fail to achieve that level of response. So that's amyloid. What about the non-amyloidogenic MGRS? And there, the data is just starting to get generated with from the oncology perspective. This was just published as a collaborative retrospective experience in May last year, looking at MGRS amyloid versus non-amyloid. There are 180 cases of amyloid and 100 cases of non-amyloid. And what we can see is, as we said, that for those patients who have the PGMID, if there is immunoglobulin detected, it's mainly the IgG kappa or lambda, as was in the case illustrated here. But the others have free light chains. But this is for those that have, abnormality that you can detect. Obviously, as I said, 70 to 80% of PGMID does not even have any light chains. And this is the distribution of the MGRS histological types in this study. As you can see, majority were MIDD, 14% PGMID in this, and obviously the amyloid group is separate here. And what we see here is, again, these patients were treated heterogeneously, so you have to keep that in mind. This is not a prospective study. So there are all these caveats, but overall, it seems that the amyloidogenic patients are doing worse than those that have non-amyloidogenic MGRS. And likewise, it does predict for outcome, both for, as we've known for amyloid, whether you achieve a deep response or not, likewise for the non-amyloidogenic. And renal response also predicts for outcome, as was made clear by Dr. Lee as well in her portion of the talk. So what about renal transplant? This is a little bit out of my league, but just to kind of close the loop, MGRS should not be at face value considered a contraindication to renal transplant. However, the risk of disease recurrence does expose the graft to risk of failure, and reducing the M protein is critical to graft survival. We have some more data, obviously, on amyloid and renal transplant. What we are seeing is that the number of renal transplants being done for amyloid is increasing relatively exponentially over time. And depending on whether the patient had hematological remission at the time of transplant or not, outcomes are different. And the outcomes of transplant also, in terms of graft survival and free of recurrence, differ accordingly whether patients going in had good control of their disease or not. But because our patients are living now 10 plus years, often people feel that even if the disease is likely to cause the graft to fail, they may still get years of quality life. So that is a discussion I do leave to my kidney transplant colleagues. I don't delve into that area. We've done very few transplants, to my knowledge, in this institution where we've shared care for MGRS or amyloid. In fact, probably none. Other than amyloidosis, in summary, there is scarce literature to support for treatment of MGRS. It's all borrowed from the amyloid literature. Clone-directed therapy is the most effective treatment strategy. Overall prognosis depends on whether it's amyloidogenic A versus non-amyloidogenic protein, level of hematological and renal response attained, and the transplant, autologous stem cell and renal transplantation may be considered in select cases. Thank you very much.
Tingting and Ravi, thank you so much for those great talks. I really appreciate it. I think we have time for some questions. Maybe I'll start. So it looks like the epi is changing in that either greater diagnosis or increased incidence and prevalence of these diseases. Is there any opportunity for either earlier diagnosis and detection and or prevention? Because it seems like people could show up on the onc side or could show up on the renal side, and most of the time it's late. Sure.
I think most cases come from the nephrology side. That's
Oh, yeah.
it. Yeah, because we get a referral on someone with either renal dysfunction or proteinuria. We work that patient up, and usually renal biopsy is the first step when we identify these disorders. But I think there are a lot of these things out there in the general population that we may not see. So detection or recognition of this, heavy disease to have that in the mind, and then see something like, oh, this could be MGRS. Let me think about this. Let's see what the term evaluation is necessary.
Yeah, I think that again, the kinetics of improvement, obviously the heme improvement occurs relatively fast. The light chains go down sometimes within a couple of weeks, and you can be in a complete hematological remission even with our modern drugs within a month or two. Uh, what we know is as far as amyloid goes, it can be a year or more before any clear organ function improvement manifests, though some subtle improvements may be apparent before that. In the case of MIDD and in the case of the MGN monroproliferative disorders, I must say that again, because each one of us sees maybe one or two a year, and I could say that yes, there's some transient improvement in creatinine that I notice sometimes, but sometimes it's oscillating. And I don't even know how long to keep going with these treatments, honestly. And there is nothing in the literature to guide us at this time or even tell us about the natural history of these patients other than the retrospective series that I've presented.
With some, yeah. So the question is, if someone presents with a mild degree of renal insufficiency, um, should you biopsy that patient? Who should you biopsy? How do you prioritize that? Um, you know, we can biopsy a lot of people. So, if one needs indication for renal biopsy, we'll biopsy that patient. If we have, mild degree renal dysfunction, if it's stable, there's the urine sediment is clean, there's no proteinuria, we may just observe that patient. If there's progressive kidney dysfunction or there's proteinuria more than a gram that you cannot explain, especially with hematuria, then we wanted to evaluate that patient carefully, and a renal biopsy may be indicated. Absolutely.